we're happy to have you, Dr. Don Buford, and he has a long list of accomplishments. And may I just read some of the highlights here? It's nice to have a board-certified orthopedic surgeon who will really speak about this, because it looks unlikely that an orthopedic surgeon should be talking about orthobiologics. But he is an orthopedic surgeon, and he is a believer of regenerative medicine and orthobiologics. And he has been treating a lot of patients and doing all these different procedures under ultrasound guidance. And he has here over 20 years of experience. And he studied in Stanford, and then he moved to USC. And then he also received a lot of awards here. And of course, he started his practice in orthopedic surgery at the University of Texas. And then eventually, he has his private clinic with an MSK ultrasound with him all the time to do his procedures. And he has written also a lot of book chapters and scientific research. So we are privileged to have with us tonight Dr. Don Buford from Texas. And so as we begin this meeting tonight, let us just pause for a moment for a short prayer. Let us pray. Heavenly Father, we thank you for this beautiful day. We thank you for your grace and your goodness, and thank you for bringing with us Dr. Don Buford to give us a lecture on the updates on orthobiologic treatment. And tonight, Lord, we ask that thou wilt lead us and help us to learn, and that we can you can help us treat our patients, especially those who need this kind of treatment. Heavenly Father, thank you for your wisdom and your grace. In Jesus' name we pray. Amen. So tonight, without further ado, I would like to welcome Dr. Don Buford from orthobiotexas.com in Texas Orthobiologics. So welcome, Dr. Don Buford. It's all yours now.
Thank you. Thank you very much. I am very, very happy to participate in this, and I am very appreciative of the invitation. So thank you very much. It's always good to have a chance to get together with friends that I don't know if we initially met at Toby or where it was, but I appreciate following you online and the communication and the training and the teaching that you give us.
Yeah, that wasn't Toby.
Yeah, I think it was Toby. Yeah. Right. So the topic of this presentation is evidence-based orthobiologics. It's a topic that I speak often on with my orthopedic surgery colleagues, but it's really a multidisciplinary talk. It's a talk that's constantly updated because the data is changing, almost quarterly. So this is the 2021 or 2021 version of this talk. I am in Dallas, Texas. You can see my website there, and I'm easy to reach on social media, and I'll give you some contacts for that at the end of the talk. My disclosures, I am the director of an MSK ultrasound training course that we've been having since 2009. We've had a 1.5 year hiatus because of COVID, but we're starting back up at the end of July, next month now, back in Las Vegas. And along with orthobiologics, we need guidance, and so MSK ultrasound was a natural imaging modality for me to learn many years ago as I started to become more interested in orthobiologics. Along with some prior speakers in this conference, Bill Merle and I think, I'm not sure if Alan Mishra's spoken, but I think Bill has. We are all co-editors of an online journal called the Biologic Orthopedics Journal, and you can see the website there. This is a journal where we are hoping to publish not only clinical science, but also basic science that's relevant in orthobiologics. So if you have any research or case studies or any content that you think would be relevant in biologic orthopedics, please go to the website. The instructions are very clear. It's a rolling publication so that you don't have to wait months or years for things to be published. It's peer reviewed. We have kind of an all-star panel of editors and reviewers. and just another place to publish information and research. As Dr. DeCastro mentioned, I'm the current president of the Interventional Orthobiologics Foundation, which is a multidisciplinary group that is ever expanding. And our goal is to be a source of education and training across specialties. And I'm very proud of the growth of that organization as well. We want to go the other way. There we go. So this is the agenda. I'm going to run through about 25 or 26 slides and be happy to take questions at the end and have a discussion. We'll talk about the dream of orthobiologics, why I got involved in it. We'll talk a little bit about allograft orthobiologics, particularly as it relates to the United States use of allograft orthobiologics. I'll spend the bulk of the lecture where we have the bulk of the evidence, which is platelet-rich plasma. And then we'll talk a little bit about bone marrow concentrate and micro or nano fragmented adipose. So why orthobiologic therapy? Well, we want to enhance the natural healing process without surgery wherever possible. And again, that's coming from the mouth of a surgeon. I always tell my patients in the office that I am all about finding the easiest, safest, evidence-based way to get them better. And if that includes surgery, fine. But if it doesn't, then that would be preferable. So orthobiologics is a chance to get our patients back to function, back to health, potentially in a less invasive way. Sometimes surgery is required, but even in that situation, there may be an opportunity for orthobiologics to enhance the healing process, either resulting in faster recovery or less morbidity or higher success rates. So orthobiologics may also have a role in the surgical treatment of orthopedic injuries. There are many orthopedic degenerative conditions, such as arthritis would be one of the big ones, where we can use orthobiologics to minimize pain and dysfunction. So in my practice, we have virtually eliminated steroid use because of the many potential side effects or complications from repetitive steroid use. And in its place, we've substituted various orthobiologics that are safe and don't have some of the negative side effects of steroid injections. The holy grail would be to use orthobiologics to prevent or reverse degenerative conditions. So I don't think we have that data and those formulas together yet, but wouldn't it be nice to be able to prevent arthritis or to be able to prophylactically treat tendinopathy in high-risk patients? And so that's something that I think future research may lead us down that path. There are many situations in orthopedics where the natural healing process and the surgical solution are suboptimal. And there is a potential safe alternative here in orthobiologics such as platelet-rich plasma, bone marrow concentrate, adipose tissue that make them an attractive treatment option. Essentially, we're not burning any bridges. And if we have a success rate or a chance at success that is greater than placebo, then I think it's worth trying as a clinical option. And again, the bulk of this talk is to cover this exact topic. We have mounting evidence that some orthobiologics may be safe and effective for multiple orthopedic uses, with and without surgery. So I'm going to spend one slide talking about injectable allograft orthobiologics. We're talking about substances such as amniotic fluid, umbilical cord blood or tissue, Wharton's jelly, exosomes, and some of the combination birth tissue products. These have been widely marketed in the United States. Today, being June 1st, is a big day in this country because today is the day that the FDA says they're now going to start enforcing their regulations against these types of products unless they're properly registered with the FDA. The FDA has the authority to approve or deny licenses for drugs in the United States. And for the past 3 years, all of the companies selling these products have had kind of a pass as they develop evidence. Most of them haven't taken the time to develop clinical evidence. And so starting today, a lot of these products are being pulled from the US market. Nobody really knows what's going to happen in the next couple months, but many companies have already announced that they're no longer going to be selling these products as of today. Part of the things that have been discovered is that none of these products that are shipped to our offices as frozen vials of fluid or particulate matter, none of these have functional stem cells at patient delivery. And that's something that's commonly not understood by our patients, because there's many studies in the literature that show that there's stem cells in some of these products, but those are all studies on fresh material. None of those studies, with very few exceptions, are done on what is actually given to the doctor or given to the patient, where it's frozen. The instructions say to thaw it out with normal saline in 5 to 15 minutes. And that process essentially ensures that there's no biologically active stem cell at the time of delivery. None of these have been approved for license or licensed for unrestricted sales and use in humans in the United States. So really, I've been on the sidelines with the allograft products. The biggest issue for me is the last one on this slide, that there's essentially no published human clinical studies, with two very small exceptions. In the United States, we have a study that was recently completed using an amniotic product for knee arthritis. And there's a second study that has been completed but not yet published on the same subject, using an amniotic fluid product for knee osteoarthritis. So we have a real lack of data that makes it difficult for me to have an informed consent discussion with my patients. So let's pivot and talk now about autograft orthobiologics. This is where we have truly decades of data that they are clinically safe and for some orthopedic conditions, very, very useful. I want to start talking first about platelet-rich plasma. What I'm trying to do in this talk is stay with publications that are within the past 2 or 3 years. There'll be a couple that go back 4 or 5 years because I think they're still the best study published, but I'm trying to stay with recent data just to show how fast this field is developing. So when we talk about hip and knee arthritis, just this year already, there's been a level 1 study published. In this study in the Journal of Orthopedic Journal of Sports Medicine, 34 patients were evaluated. The follow-up time frame was very long at 2 years. And what they found was that in the patients that had hyaluronic acid injections, 50% of those patients advanced to total hip replacement versus only 15% in the group that had PRP injection. So the conclusion of these authors was that leukocyte-poor PRP significantly delayed the need for hip arthroplasty surgery. And again, level 1 study. I'll be the first to admit that the N is relatively low at 34, but here we have a study that bears reproduction in other clinics that suggests that PRP can be very effective for hip arthropathy. Last year, there was a study published that I think is going to tip the scales in the United States towards having PRP covered for knee osteoarthritis. And I say that because this study was a level 1 meta-analysis of 30 separately published randomized controlled trials. And so that number virtually dwarfs most other orthopedic conditions in terms of level 1 studies. So here we have an intervention, PRP, that has 30 separately published level 1 studies. And so gone are the days when anyone can say that there's no evidence for PRP as a treatment for knee osteoarthritis. The total N across these 30 studies was 3,463 patients. And what the ultimate analysis revealed was that PRP was better than placebo, steroid, or hyaluronic acid at the 3-month, 6-month, and 1-year follow-up time intervals. So I think once the payers realize that they can actually give their patients better care at a lower cost, that they will start to cover PRP. And again, I think studies like this are going to really force not only the public to become aware of this option and to demand it, but also force the payers that are accepting premiums to start covering this, because it's still a cash pay procedure by and large in the United States. The medial collateral ligament in the knee. This is another location that has recent data published last year. Autologous PRP therapy was used in this study. What was nice about this study, and what we like to see as clinicians, is they didn't just pick patients that just had a recent MCL sprain from 2 days ago. These patients all had standard of care for 3 months. They were all symptomatic for up to 3 months, which is the basic time frame when most clinicians would expect a typical low or medium grade MCL to heal. Well, in these 52 patients, after 3 months, they were still having significant clinical symptoms and restrictions in their activities. And they all received 3 weekly PRP injections. Given those parameters, what the authors found was that these patients had their pain improved by 1 month, and that their pain was still significantly better, decreased that is, by the 6-month follow-up time interval. 2 more common orthopedic conditions, ankle arthritis and ankle sprains. In the Journal of Foot and Ankle Surgery in 2020, a level 2 study was published with 39 patients being evaluated. These patients all had ankle arthritis, osteoarthritis, and they all received a single 3 cc injection of PRP. What the authors published was that the pain scores decreased 50%, and this result was durable out to 6 months from a single PRP injection. Also last year, another level 2 study was published looking at ankle sprains. These are not the low grade, grade 1 ankle sprains, but these were the high grade, grade 3 sprains. 40 patients were evaluated. What the authors discovered was that the PRP group was better at 1 month and at every time interval all the way out to 1 year. So here's another example of using an autologous orthobiologic, PRP, for a very common orthopedic condition and trying to accelerate the healing process. This is something that's near and dear to my heart as a shoulder surgeon, especially. Rotator cuff tendinopathy is one of the things that orthopedic patients will come to see us for most commonly. I think if we looked at my typical patient population for orthobiologics, knee arthritis would be the #1 category. Back pain would probably be #2. And then #3 would probably be a tie between shoulder, rotator cuff, and hip and elbow. In 2020, a relatively large study was published with ultrasound guidance, 128 patients. And what these authors discovered was that patients that had a single PRP injection had about a 70% success rate in having their symptoms ameliorated, decreased. This year in Journal of Arthroscopy, another study was published using PRP. And what they discovered using the RegenLabs PRP system was that patients initially did better, although the results tended to be equivalent in this double-blind randomized trial if you went out to about the 6-month time interval. Elbow tendinopathy, like I said, is a very common pathology that patients will seek care for, along with ulnar collateral ligament. In the United States, there's been almost an epidemic of UCL pathology in younger and younger patients as we have more and more high school age or teenage patients specializing in a single sport. And if that sport happens to be a throwing sport, we're seeing a significant rise in UCL injuries in that patient population. If we start first with elbow tendinopathy, the landmark study was about 8 years ago. That was done by Alan Mishra and some of his colleagues. Again, Alan's the co-editor of Biologic Orthopedics Journal with me and with Bill Merle. Alan published a fantastic level 2 study back in 2013 that really moved the needle on using orthobiologics for lateral elbow tendinopathy. And he had 2 groups. One group received dry needling and the other group received dry needling plus leukocyte-rich PRP. These 2 groups were followed for 6 months. The dry needling group had a 68% success rate in return to function and decrease in pain. And the dry needling group plus PRP had an 84% success rate. So this was one of the first orthopedic surgeon-led studies with PRP in a sports medicine diagnosis that really showed that PRP was effective or had a chance to be very effective over other typical standard of care treatment modalities, and really led many sports medicine surgeons in the United States to start looking more critically at PRP for orthopedic pathologies. Again, another study published this year, 2021, in the Orthopedic Journal of Sports Medicine. Now, this is looking at UCL injury. This is a level 3 study with 50 patients. 64% returned to throwing after a single dose of PRP. All of us that have done this surgery know that the potential complications can be significant. The downtime can be significant. The return to the same level of activity can be unpredictable and can take a long time. And so here we may have an orthobiologic treatment option that is significantly less morbid and may get patients back to function, especially throwing function, in a much faster time frame. In this study, 72% of the patients returned to throwing, most after a single injection. So for anything short of a complete UCL tear, in my practice, we virtually always try PRP injections. In fact, I would try 2 PRP injections before taking someone to surgery for a partial UCL tear. The hand and the wrist are both areas that can benefit from autologous PRP treatment. A carpal tunnel is obviously a very common diagnosis in orthopedics. We have a study published just this year showing that a PRP injection can give up to 1 year of symptom relief for patients that have moderate to severe carpal tunnel syndrome. This was a level 1 study. So again, my colleagues that often say there's no evidence, there's no evidence. Well, there is evidence. And actually there's evidence for many orthopedic conditions that is level 1 evidence. Here's an example with carpal tunnel. This was a very elegantly designed study because these are patients that have bilateral carpal tunnel. One side gets PRP injection, the other side gets placebo. And what they discover is the side that had the PRP injection is the patient-rated better side symptomatically at every time point, all the way out to 1 year. And this is from a single PRP injection. Another common area that has degenerative arthritis is the trapeziometacarpal joint. And a couple years back, this level 1 study was published that you see on the right, where patients got 2 injections compared to corticosteroid injections. And in this level 1 blinded study, the patients that had the PRP injections at the TMC joint did better than the corticosteroid injected patients all the way out to 1 year. And so it's studies like these that are continually being published that have led me to really avoid steroid injections, especially for chronic degenerative conditions. I'm seeing a fair number of patients with SI joint dysfunction. And that study didn't pull up, so let's go straight to lumbar disc. I did mention back pain is one of the most common complaints for patients in my orthobiologic practice. Greg Lutz and some of his colleagues published a fantastic study 5 years ago looking at intradiscal PRP. This was a double-blind study as well with 47 patients. They looked at PRP injections versus contrast, and they found that the PRP group had significantly better pain and function scores at 2 months. And that from 2 months all the way out to 1 year, patients had improved function, improved pain scores and functional outcome scores from a single PRP injection into the disc. There's been similar reports in facet arthropathy at the SI joint and even with caudal epidural injections. So I want to talk, or at least summarize, the recent data for bone marrow concentrate. This is obviously a little bit more invasive than the blood draw required for PRP. The first thing that I have to consider as a clinician is it safe? Well, bone marrow concentrate, like PRP, has been used in orthopedics for over 30 years. It's safe. Study published in 2018 on the left looked at 125 patients with essentially no significant complications. And in the purple rectangle on the right, there's been over 4,000 patients results published using BMC as the orthobiologic. And so we are quite comfortable telling patients there is no increased cancer risk and that there's no significant increased risk of infection over any other injection. And so I think the initial answer or question of is it safe, that question has been answered. We know that BMC is safe, not only in its aspiration, but also in its application. Why use BMC? Well, it's a different orthobiologic. It is qualitatively different. And in this 2016 study in knee surgery, sports traumatology, and arthroscopy, Lisa Fortier and some others quantified the differences between two different BMC preparations, also comparing it to whole blood and PRP. One of the things that has been subsequently verified by other authors is that the concentration of IRAP, which is the interleukin-1 receptor antagonist protein, which is a very anti-inflammatory protein, that concentration is much higher in bone marrow concentrate compared to PRP. And so if we are interested in an anti-inflammatory treatment, bone marrow concentrate, all other things being equal, bone marrow concentrate would be the better orthobiologic choice, purely on the basis of having a much higher IRAP concentration over PRP. Our bone marrow does contain transforming growth factor, platelet-derived growth factor, many other cytokines and proteins like PRP, but it's in particular the IRAP concentration that is significantly elevated in bone marrow compared to blood. This 2019 study confirmed that IRAP is much higher in BMC and that it is a potent anti-inflammatory. So one of the things that I counsel my patients on when we're discussing platelet-rich plasma versus bone marrow concentrate is, especially for an arthritic condition that's a chronic inflammatory condition, bone marrow concentrate may make more clinical sense to take advantage of this increase in IRAP concentration. These are recently published studies. There is admittedly much less published data using BMC for orthopedic conditions compared to PRP. And once again, I've cherry-picked publications over the past couple of years just to show that the trajectory is positive. There's more and more data being published. But as we stand now, we have 2 studies published in the last 3 years for knee arthritis. These are level 3 studies. We have a study published last year on bone marrow lesions. That's a level 1 study. We have a study on shoulder arthritis. We have several level 3 studies on rotator cuff tendinopathy or osteoarthritis. We have a level 3 study on discogenic back pain. And when we look at the average level of evidence for BMC, it's about a level 2 to level 3. Now, it's interesting because the average level of evidence in the 6 top orthopedic journals is level 3. You would think it would be level 2 or level 1, but it's not. We've looked at that. We've looked at a year's worth of publications in these 6 journals and discovered that the average level of evidence is 3. And my point is, the average level of evidence, even for BMC, which doesn't have enough data, in my opinion, that average level still matches what we accept in the top 6 orthopedic journals right now. Adipose tissue, the results for adipose tissue in terms of the literature results are going to be about the same as the bone marrow concentrate results. The average level of evidence is going to be a little bit lower. Average level of evidence is about a 3 to a 4, but the data is starting to improve and the data is starting to increase. And Dr. Malanga, who was a recent speaker, is one of the clinicians in the United States who is working on clinical studies using the lipogym system or using adipose for orthopedic applications. And so this data is increasing almost monthly. We're having additional publications showing where and when adipose tissue might be useful in an orthopedic setting. So the orthobiologic evidence is growing rapidly. Most of these procedures do require ultrasound or fluoroscopic guidance. And so that is why part of what I do as a clinician is teach others in my profession on all the many different ways we can use MSK ultrasound, not only for diagnosis, but also to guide procedures. I love having this international collaboration because I truly believe it's going to accelerate acceptance and improve our clinical outcomes. So once again, I'm very grateful for the opportunity to have this conversation and really look forward to continuing this friendship and collaboration.
Thank you, Dr. John Buford, for that wonderful lecture. It was a very important update for all of us, and I can see that from where we have started maybe 10, 15 years ago, it has already evolved into what could be considered, hopefully, a mainstream treatment for orthopedic conditions, even in our Asian colleagues. So is it okay to ask questions, Dr.?
Please.
Okay. I have a very curious question to ask you.
Sure.
Okay, a lot of times we see in the MRI signs of subchondral edema, which actually doesn't show any abnormality yet if we check it on the ultrasound, and sometimes even an X-ray, we didn't see that. And I just want to cite one patient of mine. He's actually a dermatologist who complains of left hip pain. And when I did the ultrasound and X-ray, I didn't see anything. So what I did is request for an MRI, and what I saw was a subchondral edema over the femoral head and some parts of the femoral neck. And so we planned, and he's very open with orthobiologic treatment. In fact, she came for treatment for orthobiologics specifically. So what can you say about looking at the subchondral edema as basis for deciding for maybe doing any of these orthobiologics? Although in that case, I prefer to do a PRP instead as an initial treatment.
Mm-hmm. Yeah, no, I think there's no question that patients can have pain and clinical symptoms from subchondral marrow lesions. No question about it. It's happening all over the world. It's one of those things where whether you're in the Philippines, Dallas, or in Paris, France with Dr. Hernigow, we are all seeing patients that have pain, and they have MRI documented subchondral marrow lesions. The difficulty is in, assigning that as their primary pain generator. That becomes difficult because we will also see patients that have subchondral marrow lesions that are asymptomatic. Yeah. And so I think the thought process for me is exactly what you did. We worked through the easiest imaging modalities first in terms of having something readily available in the office, whether it's ultrasound or X-ray, and then progress to MRI if that doesn't give us an answer, and then have to decide on a treatment. Now, especially around the hip, I think the data is pretty conclusive that replacing or using an orthobiologic in the femoral head can give people significant pain relief. And people that have done that, myself included, have seen that happen where, it's one of those things where if you see it with your own eyes and do it with your own hands, and you have a patient who's gone years with symptoms, and now the final thing that made them better was the last thing you did, which happened to be a subchondral injection of PRP or BMC, you start to believe that. And when that happens over and over again, you start to believe that there's a place for that treatment. And so I firmly believe it's the right thing to do for certain patients. It's been studied. It's been studied in a scientific way. We know that people that have AVN of the femoral head before collapse do better with a core decompression plus a bone marrow concentrate injection, or even a core decompression plus PRP. I think we have some colleagues in Spain that use PRP a lot in the subchondral location. Of course, Philippe Hernigow has published on using BMC for the same indication. I tend to use, because the bone marrow concentrate replaces mesenchymal stem cells that live in that location. And my thought, and this is just my thought, it hasn't been clinically decided definitively, but my thought is, why not replace stem cells back where they were? And maybe that bone marrow lesion is a result of an imbalance in stem cell, production versus stem cell, destruction. And I think of it as the bank, that subchondral location where stem cells typically live. And so for me, it seems like an elegant solution and an appropriate solution to put the BMC right back in that subchondral location. And patients seem to get better from that. Now, PRP, I've done the same with PRP. PRP, as we know, it works in conjunction with stem cells, and it helps even attract stem cells to that location. And so maybe we're all doing the same thing using a slightly different orthobiologic, but the end result is we're improving the health of the mesenchymal stem cell, maybe improving production, maybe improving differentiation. So I think it's something that is becoming state of the art for those types of VMLs. I think the science going forward is going to be geared towards what size VML do you start to think about, wow, I better start treating that. Is it 1.5 centimeters? Is it 1 centimeter? I think there still needs to be some comparison studies between intra-articular versus subchondral versus combination. There's still plenty of clinicians that believe they get the same outcome with an intra-articular injection versus a subchondral, but I think the data for subchondral intervention is pretty compelling now. And I think there's going to be a lot of research going that direction.
Yeah, interestingly, after 3 months, I was just curious to see the results, and we did another MRI in 3 months, and the subchondral 90% was gone.
Mm-hmm. Yeah, it's one of those things where you can see a quantitative and qualitative change, and their symptoms get better. I would bet that patient's symptoms probably got better too.
Right.
Yeah.
Yeah. Okay. There's another question here that my colleagues would like to raise, and she's a little shy, but Pash, why don't you ask that question?
Hi.
Go ahead.
She's muted.
You're on mute. You're on mute.
See, this is how starstruck I am. I'm so sorry. Good morning from there. And
good morning.
Okay, Dr. Don,
Sure.
I just have to ask this. I don't know if this is just my feeling, but I feel like there's a lack of standardization of how these procedures are done. I feel that, you know, sometimes it's some people take a look also about the age, about the patient, aside from the degree of injury that they have. So do you find it the same in your practice, or is there a way to standardize the way that doctors treat, you know, sports injury or problems with orthobiologics, or is it too early to have a standard? Thank you, doctor.
Yeah, no, that's man, you hit the nail on the head. It starts just within reporting what we're doing. And that's been something that there's actually been studies on how we report what we're doing. and Dr. Leprade and some others, and we started this Biologic Orthopedics journal for that reason, to have a journal where we kind of force people publishing to say, what did you do? Because if I have a fantastic result in Dallas, it doesn't matter if you can't reproduce it where you are, because I didn't even say what I did. All I said was I used PRP. Well, that could be anything. And so it's a very good point. So I think you have to start with fully describing what you're doing as best you can. And in terms of PRP, there's now several published ways to quantify or describe the PRP. And as long as you pick one that lets us ultimately get to what the platelet dose was and what was in it, then I think that helps. Because I think ultimately we have to create a dose response curve for PRP, using that as an example. You know, we have to know that, okay, 6 billion platelets for lateral elbow tendinopathy, 6 billion platelets in 3 cc's gets 85% better. And so that would be the type of standardization that we're striving for. And again, it's going to have to come from using very, very similar descriptors for what we're doing in terms of an orthobiologic. But then the second part of that is being kind of internally consistent. And so in my practice, for example, if somebody comes in with knee arthritis, they get 60 cc's of blood drawn, it's PRP, 60 cc's of blood drawn. We concentrate back down to approximately 5 to 6 cc's. And so that way, at least in my practice, I'm internally consistent. Now, that I know that gets a certain percentage of my patients to where I want them to be. Say 80% of my patients get a 50% reduction in pain, just to throw a number out there. And if they need a second injection, we can do that down the road. but it's even harder as a clinic if you sometimes do 60 cc's, sometimes you do 30. I would rather, as long as I know it's safe, I'd rather have a one standard per diagnosis or per joint. I don't vary that based on age right now. But that's a common question that my savvy patients will ask, that they will have been told that my growth factors aren't as active because I'm older, my stem cells aren't as active. You know, I've looked at as much of the evidence as I can, and at this point, I don't vary what I do based on that. And I certainly believe that somebody into their 80s can have a very successful bone marrow concentrate procedure. That if they didn't have stem cells, they wouldn't be able to walk into my office. But I do think that not only being internally consistent, but also describing the orthobiologic are two things we have to do before we start even. Otherwise, we're not going to have a target to reach.
Okay, thank you so much, Doctor.
Jojo, you have a question? There's another question, Dr. Don. So, Joe.
Mm-hmm.
Yes, congratulations, Dr. Buford, for giving us a very nice lecture. I hope you don't mind if I ask if you think there is a role for orthobiologics in the management of rheumatoid arthritis. Thank you, Dr. Buford.
So certainly in terms of specific joint involvement, no question about it. And remember the true clinical difference at this point that we know between BMC and PRP is that increase in IRAP, which is that tremendous anti-inflammatory. And so when I have rheumatoid patients and we're treating specific joints, I really think that's one of the few situations where I try and get my patients into a BMC treatment as opposed to PRP, because I think they have a chance to really benefit from a little bit more invasive procedure in terms of getting the bone marrow. In terms of systemic, there are clinics in the US that have done systemic injections for rheumatoid, and that really in the United States isn't really allowed at this point. So I don't have a lot of data on that or firsthand experience with that, but I think there may be a situation where we have, you know, systemic inflammatory conditions where a treatment, it may not be PRP or BMC even, but a systemic anti-inflammatory autologous treatment may be something that's more beneficial than just the typical biologic drugs that they get that have other side effects. Does that help? I hope that helps answer your question.
Thank you very much, Dr. Buford.
Yeah.
Doctor, can I ask another question, please?
No more questions.
Okay, sorry.
I'm kidding. I'm kidding. I'm kidding. I'm kidding. I'm kidding.
Please come by to the Philippines. I think we will have a lot more questions.
Yeah.
But first, I got shocked first. But may I ask,
I'm kidding.
I'm just curious, Doctor, about do you ever get, let's say, sports athletic people who have overused their joints, and was wondering if we could do any prophylactic treatment for them? Say they don't have actual tears, but they just know that, you know, they've been overusing their joints. So do you get any patients and give in to those requests? Thank you.
I don't, to my knowledge anyway, I haven't seen a published study on prophylactic use. So if somebody says, you know, like you see on the screen, evidence-based, I don't have a published study on that. I do know that at least the two orthobiologics I use are safe. So the one condition right now, or there's a couple, I mean, you could always tell a story. There's a couple situations where I think I could justify prophylactic use. Somebody who has a strong family history of degenerative joint disease, for example. I will see people that come in where one knee is symptomatic, the other knee is not. The x-rays look the same, and they may have bone marrow lesions on the MRI scan, so they're starting to have symptoms. That may be a situation where we treat an asymptomatic joint prophylactically. But to your point about the sports athlete, I don't really have I haven't really treated prophylactically, but I will treat with very early onset of symptoms, if that helps. I think there's enough evidence for certain conditions to treat early in the disease process to modify it and try and shorten any disability.
Thank you, Doctor.
Okay, one last question, Dr. Don, if you won't mind.
Sure.
Sure. What do you think about A2M for degenerative joint disease as shown in the study of Dr. Cuellar?
Yeah. So I love A2M. So alpha-2 macroglobulin is a known, I'm saying this, antiprotease. And it's one of the things I think that allows me to tell patients that if we're using, whether it's an A2M only treatment or bone marrow concentrate, which I'll get to in a minute, it's one of the things that allows me to tell patients that we can slow the progression of your arthritic joint by using A2M. Okay, and I think that's fantastic, and I strongly believe that. I think it's a very safe statement to say to patients. I think there's been enough data collected, enough evidence showing that. We've got Philippe Hernegal with serial X-rays 10 years apart, 12 years apart, showing no significant change in X-ray appearance with bone marrow concentrate treatment. And so on that note, BMC has A2M in it. Our bone marrow has A2M. And the reason why I don't do standalone A2M treatments, and I don't want to make anyone angry, there's nothing wrong with that. But the reason why I don't is because I've been involved in reviewed research showing that the amount of A2M in a well-done bone marrow concentrate procedure matches or exceeds the amount of A2M in the standalone A2M procedure that's done from a blood draw. So for me, I can do a procedure that's essentially the same price, that has more A2M, also has mesenchymal stem cells, also has platelet-derived growth factor, also has some platelets, also has some other things, and it's more of a combination orthobiologic, where all of the things that I know about are essentially only going to be beneficial, especially the A2M. So I consider my BMC an A2M treatment, is what I'm getting at. And I firmly believe that that's one of the reasons to choose BMC over PRP when you're talking about degenerative joints.
Well, thank you very much, Dr. Buford, for your time. And of course, your very nice lecture on the updates on the evidence-based orthobiologics. And certainly, we learned a lot of new information today. And hopefully, we can invite you again in the near future. And maybe you can come and visit the Philippines soon. When
I would love that.
Yeah, when all these pandemic challenges are over, and maybe when you are okay with long haul flights.
Right, I know, right? Well, and the same, if any of you are ever, our annual meeting for interventional orthobiologics is in February in Denver, 2022. And then of course, if you're going to be around Vegas next month, anytime you're in the States, at least shoot me a text or an email, or shoot me a message on LinkedIn and let me know so we can get together. That would be fantastic.
Yeah, that would be very nice, Dr. Don. Thank you for that invitation. And we will certainly take note of that, especially if we would be allowed to go to the US, because we're constrained by our return flights, having to undergo 14 days quarantine when we go back. That means 10 days in the hotel, and then without doing anything.
Yeah, that makes it hard. I understand.
So anyway, thank you very much, and hopefully we're looking forward to seeing you in person. And thank you for this very updated information that we can use. And you be safe. You take care wherever you are, and God bless you always.
Thank you. Thank you very much.
Yeah, thank you. Thank you, Dr. Thanks.
Bye-bye.
Bye.
Thank you, my friend.
Right. You take care, Dr. Don. Take care.
Okay. We'll stay in touch, okay?
Yes. We'll keep it.